And so we are going to now move to a panel discussion, which will be moderated by my co-moderator, Dr. Landovitz. But I did want to just introduce a few panel members that have not previously been speakers thus far. First one is Pete Anderson, who is professor of pharmaceutical science at University of Colorado in Denver. He's familiar to many of us and done a very important seminal work in clinical pharmacology of anti-HIV medicines, and particularly in the PrEP space. A lot of the seminal articles on pharmacology of PrEP are thanks to Pete, and so we're very pleased to be able to have him on our panel discussion for this afternoon. We also welcome Dr. Kevin Ard, who is the medical director at the National LGBTQIA+ at the Fenway Hospital in Massachusetts. He's a practicing clinician and also a faculty member in their division of infectious diseases. His interests are in LGBTQ health and prevention and treatment of sexually transmitted infections and HIV. Carolyn Chu is an associate professor at UC San Francisco. Dr. Chu is in the Family and Community Medicine department. She provides comprehensive HIV, hepatitis, and primary care to patients at their network's Family Health Center. And Aniruddha Hazra, who is assistant professor at University of Chicago in Illinois. He's director of their fellowship program, their sexual wellness clinic, and the Chicago Center for HIV Elimination, director of STI services. So his interests are around sexually transmitted infections and their impact on gender and sexual minorities. He's also interested in complex HIV management, hepatitis C treatment, anoscopy, and treatment of opioid use disorder. And so we're very pleased to welcome him, and also welcome back Dr. Joe Eron, who I introduced previously. So Rafi, I'm going to hand over to you now to start with our fantastic cases for the panel discussion.
No, thanks, Sue. Can everyone see the slides okay? Is the sharing working okay?
Looks good to me.
Okay, fantastic. So thanks everyone for persevering with us. I know it's been a long morning full of really great information, and we're going to try and be a little bit of a pivot here and talk about some cases. These are all real cases, some actually provided to us by the panelists. And the goal of this is going to be really to talk through the thought process of dealing with these challenging situations. A lot of the time, there aren't right or wrong answers. We just thought it would be really useful to go through the thought process when using these long-acting products in clinical practice, now that we have all of the data and some insights into the challenges with implementation. So we'll see how many cases we get through. We will have about 10 or 15 minutes at the end for people who are in the audience. If you want to throw in your challenging cases, if they bring up different issues than we talk about here, we'd love to think about them with you. And we promise that we won't have all the answers either. So that's always fun. These are my disclosures. And these are our learning objectives for this session. We're just going to talk about the considerations of management of low-level viremia and virologic failure in cabrylpivirine treatment, considerations for management of these really challenging discordant results when using long-acting PrEP, and where you can get help. And perhaps this last bullet is probably going to be the most practical thing that we're going to share with you in this session of, how do you phone a friend if you were playing Who Wants to Be a Millionaire on television or something like that. Okay, first case. So this is a real case. It's actually a case that Dr. Hazra has now published. So some of you may be familiar with it, but I think it'll be really helpful for us to all hear what Dr. Hazra and his team were thinking as this unfolded. And we actually have a sort of a fun opportunity for some longer term follow-up on this particular patient. So you can pretend that a colleague has sent you an email to ask about this patient. So this is a 28-year-old gender diverse patient who was assigned male at birth. who had been on daily oral FTAF prep for about 10 months and had been doing pretty well from an adherence standpoint. There's also a history of controlled hypothyroidism and a self-report of hypogonadism that has led to, let's say, off-label polypharmacy use of a number of endocrinologic interventions, including testosterone, that's resulted in significantly elevated clinical testosterone concentrations. This individual is sexually active with cisgender men. I apologize, I was about to misgender this patient there. The preferred pronouns are they, them. So they practice condomless oral and anal sex with cisgender men. Their primary partners are 20 to 30 unique non-primary partners monthly in addition to their primary partner. They've recently begun engaging in anal fisting, and there was recent diagnoses of syphilis and Mpox within the last 6 months. The primary partner is living with HIV and has resistance-associated mutations, including a K65R in reverse transcriptase and an integrase 92G that has resulted in a somewhat unusual treatment regimen for the primary partner of dolutegravir and boosted darunavir, but there's been undetectable documented RNAs for about 2 years, although there's some rumor that there had been about a 1-month discontinuation of ART in the not too distant past. So you can probably get a sense of where this story is likely going, but we'll proceed with the story and then we'll take a break for thoughts about what you would do. So the patient decided that he was interested in CAB-LA, and he received 3 injections of CAB-LA, and they were on time. They happened at days 0, 27, and 91. And somewhat incidentally, or perhaps not, there was a flu-like illness that was associated with a positive COVID test on about day 76 in that cycle. So you can see on this little chart where in the cabotegravir injection cycle that happened. It was sort of partway between the 2nd and 3rd injections. And that positive COVID resulted in treatment with a 5-day course of nirmatrelvir ritonavir at standard doses. At the day of the 3rd injection is where the story starts to get interesting. On that day of injection, an HIV antigen antibody test was not reactive, but an RNA PCR test was detected at a level of 30 copies per milliliter. On that date, STI testing was performed and was negative. That included an RPR that was not reactive, oral, urine, and rectal GC-CT swabbing that was negative. And with that result, the patient was brought back in 9 days later and had tests repeated. On that repeat testing, an antigen antibody test was reactive. A discriminatory test on that antigen antibody test was detected for HIV-1, and a repeat RNA was detected at 20 copies per milliliter. There was a genotype attempted, but was not able to be run. Let me take a pause right there. We do get some additional information that's already on this slide, but Anu, do you want to talk a little bit about what you and the team were thinking when you got these results and what your dilemma was and how you decided to get help to figure out what the next things to do were?
Yeah, thank you, Rafi, for going through this case. Yeah, I mean, I think the 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 first emotion was like, I think, sheer confusion of trying to understand what was happening here. I think, the first test, we had a protocol in place. This was a patient at Howard Brown Health, which is the largest LGBT health center in the Midwest. We had been implementing Cabalet for PrEP for a bit of time, still not a full year, but had a decent cohort of folks. And so we had a protocol in place where every patient coming in would have a rapid fourth generation antibody antigen screen, and then would have a blood draw for HIV-1 RNA. We obviously would not wait for the RNA before administering the injection, but would at least have that pending after the patient left the clinic. And so after this first one came back, I think this was a bit confusing, and we didn't know what to make of the low level RNA. And so we decided to have the patient come back. And because of delays, and this happened literally around the holidays, which made things a lot more convoluted. We had to come back at least within 9 days, and then that point, the rapid fourth gen in the clinic was reactive, and we also sent this out to a third party laboratory, which is reactive, and then detected the HIV-1 antibodies on the differentiation assay, and then the viral load came back again at 20 copies. Going into this second visit on day 100, I think that's when we had discussions with a few other sort of infectious disease physicians that work in our clinic to really think about, we should probably get this person on full treatment while we're waiting for results to go, come back, and sort of coming back to Dr. Kelly's talk earlier this morning about, what to do with, a concern for seroconversion on PrEP, and this sort of options 1 and 3, 1, just waiting and watching, and option 3, actually starting them on a fully suppressive regimen, because obviously we can't take away the Cabalet at this point. And so we opted to start them on FTAF, and thinking that with the Cabalet, that would be a full regimen, while we waited for sort of the dust to settle with that second result. And so when the second result came back, that I think, it was hard for us to write off 2 positive RNAs as, 2 false positives of a test with nearly 99% sensitivity and specificity for HIV. And I think that in itself made us feel, I think, a lot more sure, if that's, if I can even use a verb that strongly, that this patient had potentially seroconverted on Cabalet.
Yeah, Anu, think that's really great. And, just to give a little bit more context, you can see on this slide, the team in deploying Cabalet did everything perfectly here, right? They followed all the guidelines. They had an antigen antibody test and RNAs before or sent at the time of each of these injections. So the question of whether or not there was HIV infection that antedated the starting of the cabotegravir seems pretty unlikely to me. Because I did sort of throw that bombshell into the history of the provocative question of whether the primary partner had been off treatment for any period of time. Let me ask Pete, first of all, and then I want to come back to Joe with a different question. Pete, the team leveraged pharmacology here and got a plasma CAB concentration about 30 days after that third injection, and the plasma concentration for cabotegravir came back at 1,180 nanograms per mil. And we had a question earlier after one of the didactic lectures about the use of therapeutic drug monitoring. This isn't quite that, but I think the team was trying to get an idea of, is the PK or the injection that was done somehow.
Yeah, Rafe, you went out there. Your audio went out for a second there. So but I think I got the question. Can you hear me? Okay.
Yeah.
Yep.
Terrific. I think this pharmacology is a piece of the puzzle that is useful here. And we don't have a threshold, a target yet for CAB for PrEP. I think one is coming. As we get more information and we analyze more and more breakthrough infections. But I think, Joe, Eron showed earlier that some of the infections from 083, of course, people had levels up in the 8 times the PAIC90. So, it's going to take time to really tease out the pharmacology contributions. Anyway, what I would say is that you do want to look for expected levels. Like, is 1,180 nanogram per mil expected? And in terms of population, kinetics, and it is. I would expect to see a level there between about 4 times the PAIC90, which would be about 664, all the way up to potentially 12 times the PAIC90, which is over 2,000 nanogram per mil. So person falls kind of right in the middle. I think it's a good piece of information for the case. Pending more information about a threshold that we need to target.
Briefly,
Oh, great. Yeah, I don't think we can hear you still. I'm sorry.
see your lips moving, but can't hear you. I know. Well, maybe while he's working out his technical issues, I'll just see if there's other panel members that wanted to comment on this case or how they might handle it.
Well, I would just jump in and say, there are like 4 separate tests that are positive. So I think the likelihood that this is a false positive is low. But the size of the infection, if you could talk about that, is probably very small. And it doesn't surprise me that they try, I think it was wise for Anu to try to get a proviral DNA resistance test, but that doesn't surprise me. That was negative. He probably has very few infected cells circulating. So, and what to do exactly, I certainly would be relatively confident that there wouldn't be resistance here. It's possible, of course. So it really, to me, it's about what would you choose to treat this person with?
Right.
And I think that's a wide open question, and I'm happy to comment, but I'll hold for a minute. Maybe Anu wants to talk about that.
Yeah, and I can walk through at least some of our logic with that, and then would love to hear from some of the other sort of panelists. So, we had started them sort of knee-jerk on sort of TAP FTC, thinking that would be a fully suppressive regimen. We did not know the whole partner history of the partner's genotype and whatnot until after the fact. And so after we received that information, the partner also receives care at our institution. So we were able to speak with the partner and be able to take a look at their genotype and seeing that resistance, as well as this concern that the partner may have been off of medication for maybe a few weeks in that time, made us a bit more wary about whether there was a transmitted INSTI resistance. While supremely low, and I agree, not a huge concern, I think that was enough for us to get a bit spooked, which is why we just replicated the partner's regimen for the patient we had. Again, whether that's entirely the right call, I think we can totally discuss. But I think we were going with a very limited amount of information and trying to preserve this INSTI class as much as we could. Joe, I agree. I think, we felt comfortable that, by starting them on a fully suppressive regimen, we could really avoid INSTI resistance in a CAB-LA breakthrough case, as sort of Susan Eshelman and others have shown, that able to sort of, identify these patients early can really prevent that. But then we're trying to figure out, how to suppress them. And obviously, and when Raphael joins back, he can share the screen, then the patient fully suppressed within a matter of days, which is, not unusual based on how low his viremia was. And we really couldn't get any other testing done without sort of, potentially pulling him off oral medication and leaving him just on CAB. And so we're sort of in this holding pattern afterwards. But I would love to hear sort of some other clinicians on the call, what their thoughts were on maybe ART selection and whatnot.
Actually,
there's no right answer, but Joe, you wanted to weigh in what you might have.
I think Joshua, I'll let someone else go. It's fine.
I actually wanted to ask Pete something. And so the first thing I thought about when I looked at the timeline for this case was any impact of ritonavir UGT induction. And I know that there's sources that say it's not probably clinically relevant, but I do wonder about the time of that like compared to when the next shot was, and whether that would be enough to lower the trough levels to a point where you'd have I don't know. It's very, just curious.
I kind of thought about that too, and I think it's possible that there was an interaction there that wasn't picked up, but you could also argue that it would go the other way, right? So I don't. It's not on the list of ones to to avoid, but it was interesting the timing of when that happened. Yeah.
Yeah, and yeah, we spoke with our pharmacists and trying to see, and we did sort of our own course of lit review of can that ritonavir impact, and it didn't seem like it could in any sort of meaningful way or clinically meaningful way, but it was something that was definitely something, again, another sort of interesting thing in this case.
I'd also be curious from the pharmacist if there is potentially any impact of the testosterone, like was the patient injecting in the same site where the cabotegravir was going? I think testosterone often comes in these thick, oily formulations. So I don't know if there was any impact there, but we do have the drug level of the cabotegravir, later on.
This is Carolyn. I think I have more of a comment really than anything else, but I think I'm just struck by the fluidity and the evolution of the serology-based assays that you got. And it just sort of goes back to some of the material that Dr. Kelly was talking about, sort of what if that fourth gen and antibody hadn't come back reactive, but you had a 30 and then you had a 20. I'm just curious if that would have changed your approach.
I don't think it would have personally for ours. I think seeing two detected viral loads for us would be enough. But if it was not detected, I think that would make things a lot more confusing to us. And also to say if we had not gotten the viral load at day 90 injection, the patient would have gotten the injection and come back in 2 additional months and potentially been diagnosed at that time too. But yeah, I think what we really wanted to highlight was these seroconversions on Cabolet is obviously a very rare event. It's a real event, but rare. But we'll see these rare events happening in PrEP clinics, and the majority of PrEP is not being prescribed at academic medical centers that have access to labs that can run a cabotegravir level and whatnot. It's going to be in these community health centers that have the majority amount of PrEP prescriptions. So I think for us, it was really important to start, for clinics who are implementing Cabolet specifically, to make sure they have good partnerships with academic institutions or with, because I mean, like the first person I called with this case was Raphael, and I emailed him and I presented the case to him, and he was able to connect me with Mark to get the Cabolet level done. So it was really trying to utilize that academic network to help with this case while we were treating on the other end.
Okay, so I heard that Dr. Landovitz having technical difficulties, but Fatima, I believe you can share his slides, and I think there may be a couple more concerned with this case, and then we can.
I guess in terms of treatment, I probably would have went with a just probably fixed dose combination of BF TAF, and the reason I would say that is a couple. One is that if he really had a substantial level of resistance, you might not have expected that kind of very low viral load. The 92Q is unlikely to have much provide much change in susceptibility to cabotegravir, and the issue is like kind of you're not really preserving integrase resistance. You're just kind of it's just unknown, right? I mean. Yeah. So if you wanted to use an integrase later in time for some reason, you'd still have the same conundrum. So I that's what I probably would have done. But Rafi and I have had this argument in the past, and so I totally understand where you're coming from. There's no right answer, as multiple people have said, but that's probably what I would have done.
Okay,
yeah.
So you guys, can you hear me? This is Sue.
Yes.
Okay, good. All right. I was just going to say that Rafi's having technical difficulties, but I think Fatima, if you could share his slides, we'll just go on to the next ones and maybe move to the next case. I don't know if there were any. Oh, was there anything else on the first case?
Oh, Rafi's back.
Rafi's back.
You still can't hear him.
Can you hear me now?
Yes.
Yes.
Okay, great.
Thank you. I'm so sorry about that. Technology is a wonderful thing, except when it isn't.
Yes. Carry on, Rafi. We just finished up case number 1.
Okay, fantastic. Great. Am I sharing again? Is that what I'm doing?
Yes.
Okay, no, Fatima's sharing. Okay, great. So let's go to the second case. Thanks everyone for your patience. Okay, so now we're gonna move to a treatment situation. This is a 41-year-old female who received an HIV diagnosis in 2008 during pregnancy. She was lost to follow-up after the delivery, but returned in 2013. She's got a high BMI of 48 and had a motor vehicle accident while she was back in care, about 6 years after she came back in care, and had limited functional use of her upper extremities, with complicated by chronic pain and neuropathy, chronic vomiting, potentially related to opioid use for pain and neuropathy. She'd gone through a number of single tablet regimens between 2013 and 2018. Including a boosted L-Vitegravir regimen with tenofovir disoproxil fumarate, as well as a rilpivirine-based regimen with TAF and FTC. She had ultimately transitioned to a bictegravir TAF-containing regimen in November of 2018, which she was crushing and sprinkling on her food, and had intermittent adherence with viral blips in the past. Possibly related most recently to injuries, but then subsequently she resuppressed. There was no documented history of resistance, at least since 2014, and has heard about long-acting injectables and wanted to start. So she was confirmed undetectable in April of 2023, began injectable cabotegravir rilpivirine and received a second dose 4 weeks later. The second dose was on schedule, but the viral load at the time, drawn at the time of her second injection, was 4,040 copies. Repeat labs and a genotype were collected about 2 weeks after that second dose, after those initial results came back, and the viral load was down about a log at 443, and the genotype showed an E138A and an M148I. She was resumed on bictegravir TAF FTC in July of 2023. So the question is, apparently this is early virologic failure after initiation of rilpivirine in the context of RPV resistance mutation. And Fatima, can we go back one slide? Because I think the question is, what would anyone have done anything different in terms of the decision to either start the long-acting injectables with that history and absence of resistance mutations documented? Would you have had concerns about doing that? Would you have done anything different with the initial viral load results coming back? And would you have done anything different in terms of choice of oral regimen going forward? So let's see. I don't know, Joe, do you want to sort of jump in and your thoughts on that?
Yeah, boy, this is a complicated one. Because I don't know. I think this would be a really high risk person, but on the other hand, it sounds like she's struggling at best to take her oral therapy. I don't know, you may have said, but I don't know what her viral load, her CD4 was, and whether that's also low and that she's at risk of progression. I don't fully understand the genotype. Unfortunately, you can have an E138A in integrase or in RT. So I don't know if is that an RT mutation?
It's actually a great question, and I think the person who sent this case in is not on the webinar at the moment, so I actually don't have that information.
Yeah, if we assume it's an RT mutation, which looks like maybe the way it's presented there, it's not really a rilpivirine mutation. It's a polymorphism. So I don't actually know what's going on here. It sounds like with her BMI, injections may be a challenge. But I might have tried it, and I think they maybe tried and failed. Fortunately, it doesn't look like integrase resistance was selected for, and then maybe BF-TAF will continue to be successful for her. This is one where having a cabotegravir rilpivirine level might be interesting, because I think in I don't remember the BMI you said, but in very obese people, I think sometimes it's injection failure, and there have been, you reported one. There are certainly cases of kind of injection failure where it just it goes too close to a vein, and you just have no levels, right?
Yeah,
so,
Joe, the BMI was 48, so
yeah. So I think high risk of this not being selected resistance, but actually failure of maybe the first injection. And then the second injection, maybe there's a partial response. So I don't know. It's tough. But I think back on oral therapy is probably the right way to go for this person.
Yeah, I think that the question of whether drug levels here would be useful does end up looming large. And, Pete, are we closer at all to sort of routine commercial availability of concentration testing, anytime in the not too distant future?
Not at the moment in the U.S., unfortunately. If we lived in Europe and this was a European case, we would have access to several labs there. I do think in the next 6 months, there are going to be some labs that come online. I talked to Johns Hopkins. They're planning spring 2024 and this is for CLIA, I assume, right? Where you're reporting back to the patient. And then Columbia in New York City also is going to offer, and actually Columbia says they will offer now, and they've got a sort of a temporary CLIA agreement with the New York State that they can use for about 50 cases. So if anybody's got a really challenging case, you can reach out to me and I could connect people to Columbia for that. But there's the same question of what's therapeutic. I think we have a little more information in this for this patient for treatment. There are some thresholds from the Atlas and Flare that have been proposed. 1,120 nanogram per mil for CAB, rilpivirine 32 nanogram per mil. So there are some numbers that we could use for this case. One question I have, can I go back to you all on, does this patient need a loading dose, with that big BMI, because, they have lower initial first injection, troughs, and, so you could ask, whether they needed a month load before that first injection as well, another factor.
Yeah, it's a really interesting question, both in the prevention and the treatment space. If there is a period of liability when you stop oral drugs and then immediately begin injectable, right? Both for prevention and for therapeutics, does it take some amount of time to get these suppressive or protective concentrations? I don't think anyone knows the answer, and we're a little bit of a victim of our own success, right? The trials have been so stunningly successful in prevention and so exciting in treatment that there hasn't, I don't think, been a lot of interest in investigating, these sort of odd scenarios. But I think it's a really important question, and particularly for individuals born female, right? We know that the approach to steady state takes a lot longer. It lasts longer, but getting to steady state is a more prolonged process too. And you wonder if that's what's going on here. So Pete, I think it's a really good question. I don't think we have any answers. Do you have any insights into, when Columbia or Hopkins does come online, who's going to pay for that testing? Because, is it bill going to come back to each institution and they're going to be left to figure out whether the institution is going to be able to eat those costs, or is it going to be passed on directly to the patient?
I do think insurances will pay for TDMs if there's enough justification for it. And I forgot to mention that rilpivirine actually is available in the U.S. So University of Florida will run rilpivirine, Chuck Peliquin's lab in Florida, and for about $75, per test. So doesn't break the bank. But I do think insurance, I don't know what your experiences are, but if there's justification.
No, that's great. I haven't had any experience with successfully getting insurance to pay for it, but I don't know if others have had either success or failure with getting insurances to pay for it. Any of the clinicians?
I have not, no.
Okay. All right. I guess, Joe, when you and Adia were reviewing the data on risk factors for failure in the treatment space, we talked a little bit about high BMI as potential risk factor. Does that, with 2020 hindsight, would you have had additional pause here, or again, is it just so personal?
Yeah, I mean, I've been asked this, and I think that, when you look at the data from the Chloeorchins, I mean that BMI is not a risk independent, or it's a tiny risk, but we're talking about BMIs 30 to 40 mostly, not 48. And I've been actually asked this exact question, and I don't know whether it's. I would be very anxious about someone with BMI in the high 40s, or I was asked about someone who was above 50, and I just said I'm just not confident you can get the medication where it needs to go more than kind of some relationship to the size of the person and the pharmacokinetics. Really, if you don't, like you said, if you don't get if you don't create that nodule, essentially, that structurally you want to create a nodule. Actually, if you don't do that, then in the right space, you're not going to get prolonged exposure. So I don't know. Pete may have an idea about that. I think you just don't get it where you need it to be.
Yeah, and it's that slow approach to steady state that you mentioned, Rafi, that I would worry about as well. So it's going to start very, very low in the first injection. Even if you're, getting it, you miss the muscle and hit the fat, it's just going to be a slow increase up to where you need to be. Getting back to the question of whether these people need loading doses.
Yeah.
Different
in Boston, how are you guys approaching this? Are you thinking of people with really high BMIs as potential exclusion criteria? Are you having trouble sourcing these longer needles? I've heard that in some geographies, it's really challenging to find the 2-inch needles, which you might, really want to have on hand for these higher BMI patients.
So great question. I'm not aware of any issues sourcing the needles in our location. I think we would certainly think about the BMI in this patient being 48. And I think it also just illustrates how many of the patients that we're kind of discussing injectable treatment with and who are interested in injectable treatment are not, people who would probably have been in the clinical trials of this. And, this is so common now. This person was on a rilpivirine-based regimen with maybe intermittent adherence in the past. They have the high BMI, but yet they're really struggling with oral therapy. And so you're kind of then thinking about the injectable. And there are many, many other scenarios like that in our practice. And I think this case really highlights the challenges that we're facing. I think I potentially also would have offered and pursued injectable treatment for this patient, given the struggles that she's having. But many of the questions that we're facing are kind of not, they're the ones in these case series. They're not the ones in the clinical trial.
And Carolyn, let me ask you, right? I think this is one of the the most frustrating clinical scenarios that we're all facing these days. You have somebody who's got previous sort of intermittent adherence to an NNRTI-based regimen. You don't have documented virologic failure on that regimen, but you have this question of spotty adherence. And it feels to me like we're hearing these anecdotes from all over the place of exactly that. Intermittent adherence on an NNRTI regimen, you can't show that there was virologic failure on it, but then we have a case of failure on cabrilpivirine. Are you seeing that? And how are you using that history or lack thereof in your decision making?
Yeah, thanks. So I'll sort of answer in two scenarios. I think in my own practice, this would have been someone that I would have been open to, offering the Cabril for, but I would have been very nervous. This would not have been a patient that I wasn't nervous about. We are hearing about cases like this on our HIV warm line and HIV prep line, and I think that this is just very, very common, where providers have assumed care for someone that they have minimal to no prior information on. I think for me, the report of being mostly suppressed on these 3 orals is probably what would have said, okay, maybe that's just all I have to go on at this point, right? And to offer the transition or the trial, or an attempt at this. I mean, this is a patient where I would have probably done a lot more counseling up front. Like, if this doesn't work, this is going to be our plan. This is not someone who I think I would have sort of only brought that conversation up after the fact.
And Carolyn, since you already brought this up, and we are going to have some of your contact information for your warm line at the end of the slides for people, but could you talk a little bit about how your group assists people and what kinds of questions that you're sort of set up to assist people with?
Yeah, so I think our group in general really encourages providers to do due diligence in terms of history gathering. It is possible to get records. It's not always easy, but it is possible. And I think for these scenarios, getting access to those records is going to be more valuable than not. I think, if you are able to get them, it's going to be time well spent. So I think our approach is, get as much history as possible, sort of lay out what the options are. We encourage individualized decision making to just make sure that the patient is part of the conversation and engaged. And then, depending on whatever the case is, we will talk about what the various oral combination options are if it doesn't feel like the right thing to keep someone on injectable Cabril.
Okay, great. Anyone have any additional last comments on case 2?
I have a couple of comments. First off, I think that this case makes me a little bit nervous just because of some of the things that have already been highlighted, notably the BMI. But I think somebody in the chat here not too long ago talked about doing a DNA archive in somebody that had previous rilpivirine exposure, and I think I would probably opt for that, I guess, when thinking about this. But what I really wanted to talk about was something that we've seen on a couple of occasions where, and it specifically happens, it seems, with folks that have a BMI over 30, is a leakage at the site of injection. And if you inject and you have some leakage, what does that mean? How do you quantify that? Beyond getting the drug to the muscle, I mean, that's clearly not even in the body. So it makes you wonder, what type of, is that an administration challenge? What is that? Is it a BMI thing? I'm not sure, but something to consider.
So Josh, since you brought that up, is there standard guidance for what you do if you see visible leakage of the product at one of the injection sites? I mean, what's your best recommendation?
I don't really have a good recommendation on that. I mean, the few times that we've seen it's been minimal from what I understand, but still, it's hard to quantify. And
I mean, I guess the one thing is, then you wonder if that's sort of a situation where you might need to do bridging. If you're concerned that someone didn't get a full dose, you're not going to be comfortable, administering another full dose because you don't know how much was gotten. And, for that 1 or 2 month period, do you need to bridge? And, I don't know if anyone else would try and do that in that situation, but it seems like that'd be sort of the safest option.
Yeah, and I think, the PK on that, it would be super interesting as has been brought up already. If you switch somebody like that to a every month injection versus every 2, there's so many questions that I don't think are really answered yet.
Yeah, I mean, just to harken back, just as we get ready to move to the next case, something that Joe mentioned, there's this really fascinating MRI study that was done by a group at Hopkins, in collaboration with the manufacturers of cabotegravir, that showed that, even with appropriate needle lengths, it's amazing where a presumed intramuscular injection actually lands. Right, it very often lands in the subcutaneous space, even when you think it's intramuscularly. Sometimes it's intramuscularly, and there's one really wild report of the injection ending up retroperitoneally. So I don't know how that got there, or the anatomy is a little frightening. It's almost a kidney biopsy, but just a reminder that as precise as we think our injection techniques are, people's anatomy is different, where they store fat is different, and the PK of these drugs is incredibly variable interpersonally and even interinjectionally within the same person, and it's something we really don't fully understand. So it really begs the question of how therapeutic drug monitoring is or isn't going to play a role in how we use these drugs moving forward, or are we never going to get the answer and we're going to get better drugs before we get an answer to that. So it's all super interesting. Anyway, I don't want to belabor the point here. Let's Fatima, let's move on to the third case. Okay, we already did the what would you do, and we answered that so completely. Okay. So now we have a 29-year-old cis male who received an HIV diagnosis in 2007. The HIV was complicated by severe chronic kidney disease, presumed secondary to HIV-associated nephropathy. We don't know their BMI. They initiated ART on a boosted L-vitegravir with TAF regimen that was complicated by non-adherence. The patient suppressed after transitioning to a bictegravir TAF-containing regimen with self-reported good adherence. CKD ultimately worsened, with the creatinine clearance dropping below 30, and then was transitioned to a 3TC dolutegravir rilpivirine-based regimen and remained suppressed thereafter. Lost to follow-up during COVID, unfortunately, as we saw with a lot of patients, but re-engaged in 2020. In December, needed to start hemodialysis. We don't know exactly what the indication for starting dialysis was at that time, but had been off ART for about 9 months. Restarted a TAF FTC boosted darunavir regimen while awaiting repeat genotyping. Genotyping did not have INSTI mutations, but was kept on the darunavir containing regimen and suppressed to undetectable levels, as you can see in this little graph here. Patient expressed some interest in the injectable rilpivirine, started the 30-day oral lead-in period before starting the intramuscular version in March of 2022. Initially was virologically suppressed on the injectable rilpivirine, and underwent a deceased donor renal transplant in October of 2022. Unfortunately, on admission for that transplant, the viral load came back at 4,150, and a genotype had the K101E and N348I mutations in RT, and then integrase E138A. There's Joe Eron's favorite question right there about whether this E138A was in RT or integrase. Here we know for sure, as well as G140S and Q148R. So the patient was transitioned back to the boosted darunavir containing regimen and slowly suppressed. But obviously with the transplant now having been performed, the drug-drug interactions are going to be a beast to deal with. So I guess the question is, with that previous history, actually, let's go back, Fatima, just so we can see the timeline for what happened here. And the exposure to the only NNRTI that we know about being the rilpivirine as part of the dolutegravir rilpivirine, were there any clues here that would have made you say, don't try this? So Anu, I think this was your patient, is that right? Or you were involved? Do you want to talk about what you guys were thinking?
No, this was a patient, like you said, re-engaged in care after COVID-19, had progressed. The creatinine clearance just continued to decline, and he actually was admitted in the end of 2020 for sort of acute and chronic renal failure, and started on dialysis that admission. And that's when we were able to re-engage in care with him. And the reason we had to cobble together a regimen was because he was in that gray area prior, between, a creatinine clearance less than 30, but not on dialysis. But since he was on dialysis, it opened up a few different options for us. But we opted for the boosted darunavir, just given the concerns for adherence with his prior regimens, as we waited for the genotype to come back. But as the genotype, at least at that point, with his viral load at like 71,000, didn't show any sort of concern for mutations, we gave the option of switching, but the patient felt okay with continuing. And personally, we feel like there is more forgiveness with missing doses of a PI, so we felt more comfortable continuing that PI based regimen prior to transplant, or prior to his desire to switch to injectable cabenuvaline.
So Anu, maybe you can share with us, how did it go being forced into a position where you had to use a boosted protease inhibitor in the context of the immunosuppressive medications? Yeah,
I mean, it was kind of, so the patient came in for they got a call that the kidney was ready, and they came in for their transplant, and they were suppressed just about 3 weeks prior. So this all happened in a matter of weeks that they unsuppressed. And so thankfully, I mean, it didn't hold up the transplant. I think that was a concern that I was having, like, oh, but they actually, it takes so long for the viral load to come back. They actually finished the surgery, and then we found out the viral load afterwards. But yeah, putting them back on the PI was a major discussion with our transplant team, and nephrology team and ID team, trying to figure out how do we dose his tacro moving forward. And I think we were able to titrate that dose while he was admitted post-transplant, so at least that was important. What was a bit confusing, and I'm interested to know for other folks, we expected his viral load to come back, I think, quicker than it did. Like, he didn't fully suppress for nearly 3 months after restarting on sort of what we consider to be a suppressive regimen, which also made us a little bit nervous, to be honest, at the same time. But we were at least able to titrate his anti-rejection medications during that admission. But obviously, this is something that he'll have to deal with for the rest of his life.
It also comes back to something I think Carolyn brought up earlier with, these questions of, what kind of conversations do you have with somebody if they opt to go on rilpivirine in the event that it does fail, and people sort of make that decision anyway, that, the consequences aren't just, a potentially less tolerable regimen, but, who knows what the future holds for any patient. And, as we all get older, we all need polypharmacy, and there's so many drugs that have interactions with boosted protease inhibitors that it becomes a non-trivial conversation, particularly with aging populations, right? I mean, statins are basically going to be in the water, right? Particularly for anyone living with HIV at this point, and these are going to be complex interactions. And Pete and Josh, I don't know if from a pharmacology standpoint, how would you ever sort of think of that as a contraindication, or is that something that it's just part of the conversation as you discuss this with people? It sort of pushes your seesaw one way or the other.
I mean, luckily we can do TDM for the immunosuppressants, and that Now, all roads are leading back to TDM with all these cases. I'm like, you know, the importance of drug concentrations, but I do think you can manage them, you know, with levels.
And Josh, coming back to something you talked about on the last case, you know, is this somebody, again, with the retrospectoscope and, you know, the armchair quarterback, would you have tried to do a GeneAssure before making that switch? I mean, we seem to be talking about that in a lot of these cases. Of course, these are select cases where things went sideways, right? We're not talking about in all the cases where things go just fine and swimmingly. So, you know, I don't want to color everybody's you know, perspective by saying we should do it in all cases, but, you know, how are we going to figure out, you know, judiciously when to use that testing?
I probably would. And I mean, the thing that really strikes me with this person is they were out of care for, you know, what is that, 9 months or whatever. And that to me, that tells you kind of enough they're already kind of high risk, I guess I would put them. And, you know, whether cabotegravir or rilpivirine is the right move for that specific person or not, you know, it's really hard to say. Could have been, definitely, but, you know, with regard to what Pete said earlier, I don't really worry about like immunosuppressants. I mean, certainly it's a risk with DDI and everything, but it's if the whole treatment team is in tune, right, and everybody's talking, which, you know, sometimes that doesn't always happen very well, then it should be managed pretty easily, to be honest. But this patient just seems really challenging, just all the way around to me.
But I mean, I'm going to vouch for the patient here,
That's right.
and say that he was out of care where majority of our populations were out of care during this time, and we did get a genotype, you know, when he re-engaged in care, which didn't show sort of any concerning mutations, and so we didn't feel the need to, you know, undergo a GeneAssure at that point, since we had, you know, detectable viremia and I just, you know, I have to, you know, we've talked about equity this morning, and I think it's important to recognize that, you know, patients with social determinants that largely impact their adherence may be the ones that may benefit the most from, you know, on long-acting injections, and we've talked about that too. And so I think it's important for us not to be gatekeepers with thinking about who can benefit and who we consider quote unquote high risk for long-acting injections, but really having, you know, a really comprehensive sort of patient-centered discussion, shared decision-making around, you know, what happens if things do go south, what is plan B and C if that happens. And I do think that needs to happen more in the clinic rooms than have been happening since we've been implementing long-acting treatment.
And Anu, did you guys think about doing anything wild and wacky, like throwing ibalizumab or len into the mix, given the previous rilpivirine dolutegravir exposure, or did that not even come up?
You mean when for their desire for long acting, or after the failure?
No, before.
Oh yeah, so len wasn't an option. It wasn't. Well, no, it would have been. I think he wouldn't meet criteria because he didn't have multi-drug resistance, at least at the time when he was interested in long-acting injections. He had wild-type virus from the most recent genotypes we had, and the ipilimumab, I think, in addition to his dialysis that he's coming in 3 times a week, then coming in every 2 weeks for another infusion, it's not something we even considered. He came in interested in long-acting treatment, and we thought, again, as someone who's had issues with adherence in the past, maybe this would be a somewhere. And he did well, obviously, for a few months, but this just shows. And again, he didn't miss any, like all these injections were on time, so it wasn't like he was missing doses or whatnot. So, you know, I'm not entirely confident of where we would, like what he could have done differently versus this potentially being what Joe was mentioning, that 0.5% failure rate that we see that unfortunately just happened in someone right before they went in for like a kidney transplant.
Okay.
Yeah, I think that the only potential lesson here is, as you know, when someone's off therapy for 9 months, the genotype on the viremic sample, you know, may not reveal the mutations that lead to some sort of fitness, and therefore that you see a wild type virus when I knew I would have done the same thing. I would not have gotten an archive genotype. I would have done exactly the same thing you did. But everybody's smart in retrospect. So maybe it's weird because he was. Well, I guess we don't know for sure. Do we know for sure that he was suppressed on 3-TC dolutegravir ropivirine?
He was right before he lost care for.
Oh, really? Okay. So yeah, I don't know what to say except for I think incredibly bad luck, and it's one of those people that doesn't make it for whatever reason, and unfortunately selected for an array of integrase mutations that really, I think, pretty much wipes out twice daily dolutegravir. Just really not a good spot for.
I think the question we were grappling with was heading into his transplant. The plan was actually to enhance his regimen by adding an oral regimen, because there just isn't data on cabotegravir ropivirine in a or in the immediate post-transplant period. So we were planning on adding potentially TAF based on how his renal function studied after transplant, or another potential NRTI.
Yeah, no, that would have been a good thought. The one thing I was going to ask Pete really was that you talked about a loading dose and not in this case, because I don't know how large this person was, probably maybe not that large, but as opposed to a loading dose, you could actually just extend the oral therapy, right? Give someone an injection, but don't actually stop their oral therapy. In someone with a very large BMI where you're worried that it might be 2 to 3 weeks, you could actually do that. The drug interactions, it's really not that much of an issue. I hadn't thought of that as an approach. So that's all something that could have been done. In this case, I don't know what could have been done, except you did what you thought was best for the patient, and it just didn't turn out as well as it could have.
And you tried the oral lead-in, it looks like, with the cab ropivirine, I assume.
Yeah, this was one of our first adopters, so we actually still you had the oral lead-in is mandatory for all of our when we first adopted our initial protocol for capital ropivirine.
But Joe, it's something that we definitely, I think, is something that people should keep in mind, with starting either injectable prevention or treatment, is it isn't crazy to do some amount of overlap, and particularly
not crazy at all.
Particularly, with individuals born female, right? But even individuals born male.
Yep. No, I totally agree with you.
My BMIs, yep, totally agree.
And just so the audience is clear, there aren't data that support that yet.
Right.
that you're hearing people who are just, seeing a lot of this muse about things that might make sense. So please don't run out and tell your colleagues, they told me to do this. We're just saying that in some of these complicated cases, it might not be unreasonable to, we talk of cover the tail in prevention, but is actually the question we want to be asking, cover the nose rather than cover the tail in both treatment and prevention? And no answers, just more questions. I'm sure we're being tremendously clinically helpful to you all here. Fatima, can you just go to our last slide? This just shows you that I bit off way more than we can chew. I had 7 cases for us.
Wow.
And we're way out of time, but I wanted to put this up. This is really critical. This top number here is Carolyn's group. These are really complicated cases without clear answers. And here is your phone a friend, right? You can, this is the group that has the funding and the expertise, to help you when you get these really complicated questions. And it's really important that you have this website and these numbers easily accessible, because we don't have all the answers to all these questions, and you really want the best advice helping you. There are a number of investigational studies that are going to help us answer some of these diagnostic questions in the PrEP space, including the SeroPrep study at UCSF. I apologize with my sort of loss of of audio function there in the first case. I don't know if you all talked about this, but this question of Anu's patient, now all his HIV testing is negative, a year and a half later, and we still don't know his actual HIV status this late. And is it possible that his reservoir was set up so in such minuscule levels that ART to this point has actually cured him just with straight up ART? At this point, we don't know the answer, but there's a study that is going to try to answer this question. It's called ACTG 5321. So if you get a CAB PrEP failure patient whose viral load never gets above 1,500, please let us know, let the ACTG know. We'll find a site nearby to you that can get that patient enrolled, because we need to answer that question. This really low viral load smoldering viremia with the really difficult to ascertain and discriminate HIV test results, we don't know what it means, and we need to figure that out. But it's pretty clear we need better diagnostics as a piece of that. Just coming on the last couple of minutes to a couple of questions that are in our chat. We had a question of leakage with a Z-track technique. Someone said they thought that a Z-track technique really should help with that. I don't know, Pete or Josh, do you have any sort of commentary on sort of the pharmacology or leak techniques of various injection strategies, or anybody else have insights on that?
Yeah, I'll just say, remember, there's a small number of people, but the times it's happened to us, we've done the Z-track method. So it's after you let it come back, and then it comes out. But yeah, I mean, that's the whole purpose of the Z-track, right? To kind of lock it in there. If it doesn't lock it in, potential problem.
So, Rafi, I noticed in the Q&A, there's quite a lot of questions about, like you said, the confusing nature of the antigen antibody tests in these complicated PrEP scenarios. And so I don't know if any of the panel members wanted to type in any responses, please feel free. There were a couple about potential cross-reactivity with COVID testing, which I don't know if you want to comment on, or anyone else.
Yeah, I'm not aware of any data of false positive HIV testing in the context of COVID. I'm not sure if anyone else is. I do think the one sort of thing that is really provocative about Anu's case there, right, is you have what we call orthogonal tests that are positive, right? You've got antibody tests and you've got viral load tests that are positive. It's kind of hard to imagine what's going to result in that as a false positive. So you're sort of stuck in those sorts of situations. Anyone else aware of any sort of COVID related things that might?
The only thing I would say about COVID is that both COVID vaccine and COVID infection, if you check a viral load a week after a COVID vaccine or COVID infection, that person is very likely to be viremic because of release from, we had one person uninjectable, who was in the 4,000, and after a vaccination, it was like a few days after, and then a week later, because we called them in, blah blah blah, it was not detected. So that's the only thing I know of. I don't know of false positive testing.
There was a report in CID of false positive antibody antigen tests in the context of active COVID infection, or a higher rate of that. But I mean, again, in this patient, you have multiple tests suggesting HIV infection. And so, I think this is actually one of the cases of likely HIV infection during long-acting PrEP that's maybe more clear-cut that the person truly has HIV. With many others, it's actually, I think, more challenging to sort out. And, sometimes there's just the HIV RNA of 30 and then everything else negative subsequently.
Yeah.
And was that a false positive? Was it not? It can be challenging.
And Kevin, to your point, thanks for bringing that up. I'm sad that we didn't get to a case of exactly that. But no one knows the right answer for how you manage those really challenging situations. I will just put out there that the ongoing open label extensions for 083 and 084 are trying to figure out, what is the sensitivity and specificity, positive predictive value of an isolated, positive, RNA at the lower limit of quantification, and what do you do with that? We don't know the answer now. What the studies are doing is they're using the following rubric, right? They're saying a single RNA value greater than 200 copies on just one measurement, they're recommending treatment. Or 2 separate date draws, any detected RNA at any level, even if it's below the level of quantification, that also is the approach to recommend therapy. Is that the right approach? No one has any idea. But that's what's being studied. And so we'll at least be able to report on it. But I think the take-home message is we need better diagnostics. Kevin, I don't know if you want to sort of comment on that, since you had a really vexing situation of exactly that.
Yes, we had a patient who was on time for his CAB injections, had all the kind of initial negative testing, negative HIV RNA, negative antibody antigen at all the time points, and he came in for his 3rd injection, had his testing drawn, received the injection, and he had a detected but lower than 20 HIV RNA. His other testing was negative, and it's really a quandary on what to do. If you look at the CDC guidance, they say that you can potentially sort this out over 1 or 2 weeks, and I think that's not the case in many of these scenarios. It takes much longer. For our particular patient, we went with kind of option 1 that Colleen Kelly talked about. They've remained on PrEP, and all subsequent testing, including qualitative RNAs, have been negative. So there was just that single, less than 20 HIV RNA. So I think, only time will tell, and potentially more data will tell what the best approach is. But it is quite challenging, I think, in clinical practice. And even though the HIV RNA is a very sensitive and specific test, there are potentially false positives. And the more people you have on CAB who are all getting at least 6 RNAs per year, I think in any program of any size, you're likely to encounter true false positives with some regularity. So I think more to be seen.
Definitely. All right. Well, we are at the end of our time together. So I would really like to thank all of the panelists for their really insightful and great comments, and for everyone in the audience for sticking with us and putting your great questions in the Q&A. The ones that we didn't get to, we will try to get back to you as soon as we can with answers to your questions.